Today's featured presentation is entitled Universal or Opt-out HIV Screening in the Underserved Setting. It is presented by Dr. Bernard Branson, who has been involved in providing HIV care, counseling, and testing for more than 25 years. Currently, he is the Associate Director for Laboratory Diagnostics in the Division of HIV/AIDS Prevention in the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at the CDC. Dr. Branson has been the chief architect for CDC's activities surrounding new technologies for HIV testing, including rapid HIV tests and tests for HIV incident. Most recently, he was the lead author for CDC's 2006 revised recommendations for HIV testing for adults, adolescents, and pregnant women in the healthcare setting. Application for CME credit has been filed with the American Academy of Family Physicians and is still pending. There will be an extended question and answer session after the presentation. However, please feel free to submit your questions and or comments throughout the presentation. Dr. Branson is willing to answer them and feed them into the presentation as we go along. So to submit a question to the presenter, simply type it into the Q&A box and click submit, and he will read it as he goes along. So with all of that said, ladies and gentlemen, let's welcome Dr. Branson.
Sabrina, thank you very much. I appreciate everyone joining us tonight. I would like to start by saying that I don't have any financial associations to disclose with anyone who would be featured in the presentation. I'll be talking tonight about HIV testing for every patient, universal or opt-out HIV screening in underserved settings. I'll start by talking a little bit about where we are with respect to HIV testing and late diagnosis, attempt to answer why we should be screening for HIV, address a little bit about how we are doing, and then go into some issues related to new directions for HIV testing. In terms of HIV infection, the CDC estimates that about 1.2 million people in the United States have HIV, and about 20% of them, or just over 236,000, are not aware they're infected. In addition, about 50,000 people become infected with HIV each year in the United States. HIV is not very evenly distributed in the population. African Americans account for about 52% of all HIV cases as of 2009, whereas they represent only 13% of the U.S. population. Hispanics are slightly disproportionately represented, being about 18% of cases of HIV and 13% of the population. But there are several other features of HIV, one of which is that in addition to being characterized, as you may see here, in some of the large metropolitan areas like New York, Washington, D.C., Maryland, and California, there is a considerable increased rate of HIV infection across, in particular, the Southeast and in many places the rural Southeast. So it's not only an urban condition, but it's something that is manifest in both urban and rural areas. In terms of the estimated rates of new HIV infections, and I need to distinguish here the difference between new infections, which is the person who acquires HIV as part of a new transmission, and new diagnoses. A new diagnosis is when someone first comes to the attention of the healthcare system as having HIV. This estimate is based on new infections that occurred in the U.S. in 2009. And as you can see, the rate per 100,000 among blacks and African Americans, which is about 70 per 100,000, is nearly 8 times the rate among whites. The rate among Hispanics, 26 per 100,000 population, is nearly 3 times the rate among whites. So that while overall the rate of new infections is about 19 per 100,000, there are considerable differences in different population groups. Again, the rate of infections among males, nearly 30 per 100,000, is a little more than 3 times the rate among females, which is 8.6 per 100,000. I think another important characteristic, especially if we're talking about underserved populations, has to do with HIV, and this now is HIV prevalence, the total number of infections as distributed by income. CDC does a national HIV behavioral surveillance in 3 phases. 1 year it's done among men who have sex with men, 1 among injection drug users, and the 3rd year among heterosexuals. And these data look at HIV prevalence stratified by different income levels. And as you can see, HIV prevalence is particularly increased among people in the lower income levels. In fact, looking at the overall U.S. population, on the right here, you see the rate among blacks, Hispanics, and whites in the United States general population, and more than 1.5% of African Americans in the United States are believed to be infected with HIV. But the disproportion between the races and ethnicities, blacks, Hispanics, and whites, that shows up in the whole U.S. population is not the same. In areas of poverty, rates are high among all three population groups. And so there are not only differences in geographic distribution of HIV, but it's quite clear that HIV infection tends to occur most frequently in areas where people have the fewest resources. This is a graph that looks at AIDS diagnoses, deaths, and the number of persons living with AIDS in the United States, and the trend since 1985 in the United States. And what you see is that early in the epidemic, through the 1980s into the early 1990s, the number of AIDS diagnoses increased nearly exponentially each year, and the death rate was extremely high. In 1993, CDC changed the case definition of HIV and AIDS, and so there's a slight difference in the number of cases. But in particular, in the mid-1990s, with the advent of effective antiretroviral therapy, the number of AIDS diagnoses that were made each year, as well as the number of deaths, decreased precipitously with therapy and has continued to decrease as the proportion of people on therapy has continued. What you see there in the yellow line, though, is the number of people who are surviving with HIV and AIDS, and that number continues to increase. And obviously, that's what we're looking for, is so that people who have HIV and AIDS do, first of all, people with HIV do not go on to develop AIDS, the latest stage of the disease, and that people with AIDS basically have longer survival. But what it also tells us is that the overall number of people with HIV in the country continues to increase. Now, since the number of new infections remains stable at about 50,000 per year, while the total number of people with HIV, the number of people able to transmit HIV, continues to increase, what that tells us is that the transmission rate for each person is going down. If the number of infected people is going up, but the number of new infections is not going up, it means that the number of transmissions is actually decreasing. I want to talk for a few minutes about HIV testing, because I think most people are not familiar with some of the details of the evolution in technology for HIV tests. First of all, there are several approaches for HIV testing. The most common one that had been employed for a long period of time is what most clinicians do, diagnostic testing, or performing an HIV test based on clinical signs or symptoms in a patient who presents to their practice. Targeted testing is something that had been recommended based on the epidemiology of HIV. That is, performing an HIV test on subpopulations of persons who are at higher risk based on either behavioral, clinical, or demographic characteristics. Classically, targeted testing has been directed toward men who have sex with men, toward injection drug users, and toward people who trade sex for money or drugs, or have a large number of partners. What we're advocating now, however, is screening, and that's what I'll be talking about more this evening, which is performing an HIV test on all persons in a defined population. Now, part of the reason for this has to do with late testing. Many people with HIV are diagnosed late. That is, their first HIV-positive test occurs within a year of the time they receive an AIDS diagnosis. Now, the time from infection, on average, until the development of AIDS is approximately 10 years. And so if a person is first tested for HIV within a year of developing AIDS, that means that they have been infected and potentially infectious for almost 10 years before their first HIV test. In this analysis, looking at reasons for late testing, what we see among the people tested late, shown by the red bars, is that nearly 2/3 of people who were tested late were tested because they were already sick. They had developed symptoms and were in advanced stages of disease. And what we're seeking to do with the screening recommendations is to shift this curve over so that a larger number of people are tested as part of their routine checkup, and optimally will have their HIV infection detected early in the course of illness when there still is maximal opportunity to benefit from the available therapies. Late testing, however, for HIV is very common across the country. This looks at the trends over the 10 years from 1996 to 2005. And what we see is that the number of AIDS diagnoses in recent years has remained relatively common at around 35,000. That's relatively constant. And the proportion of people who were tested late, that is, were tested within 1 year of receiving AIDS diagnosis, although it's diminished slightly, still accounts for about 1/3 of all new diagnoses of AIDS. People developing AIDS within 3 years, and again the interval from infection to development of AIDS without treatment is usually 10 years, still represents, although there's been some diminished, nearly half, or 45%, of all new diagnoses. And so part of what we're seeking to do is not only see to it that all people with HIV are diagnosed, but that they're diagnosed earlier in the course of their disease because of opportunities for treatment. Now, CDC took a look at where HIV tests were conducted in general, the largest number of tests, and where most HIV positive tests were conducted. There's an annual survey called the National Health Interview Survey, which is a household-based probability sample in the United States that has asked questions about AIDS knowledge and behavior since in the mid-1980s, and they also asked people if they have been tested, not including HIV tests for blood donation. And what these show is that between 18 and 20 million adults between the ages of 18 and 64 are tested annually in the United States, and the vast majority of those people get their HIV test from a healthcare provider. The largest number, in fact, from their private doctor or health maintenance organization, followed by tests done in the hospital itself as an inpatient or the emergency department or as outpatients. In interviewing people who tested HIV positive when this is conducted for HIV surveillance, what we see is that physicians in healthcare settings also identify the vast majority of HIV positive, they're responsible for the majority of HIV positive tests. So that private doctors or HMOs identify about 25% of HIV positive tests. A similar percentage occurs from people who are tested in hospitals, emergency departments, or outpatient clinics, and another 10% of people in community clinics. Although there has been long established targeted testing in HIV counseling and testing sites, as you see here, they account for only about 5% of all HIV tests annually and only about 18% of HIV positive tests. And so obviously, in an attempt to increase the number of diagnoses, it seemed that we should concentrate on testing where most testing occurs, and that is in practice settings, in hospitals, and in community clinics. So the big question is, why screen for HIV? And first I want to talk about screening in general. I think most of us are familiar with newborn screening. Each newborn is screened for inborn errors of metabolism and hypothyroidism, both at birth and at about 1 month after birth. And these data are from the screening program in the United States, where 3.7 million infants were screened twice for PKU, for galactosemia, and for hypothyroidism. And what you can see is out of those 3.7 million infants, a very low number of cases of each of these conditions were identified. The most frequent is hypothyroidism, 1 in about 3,300 cases of screening overall. And because of this very low prevalence, the positive predictive value of newborn screening, the likelihood that a positive screening test means the presence of disease, is actually very low. The highest of them was about 3% for PKU. But the reason, obviously, for doing this screening is that there is a major opportunity for intervention. If you don't identify PKU or hypothyroidism or galactosemia early, and you don't effect dietary controls or medication, it is that it has very severe and very long-lasting consequences. And so screening is justified in this setting because of the opportunity to institute therapy when it will be most beneficial. Another example of screening is for cervical cancer. And this compares the annual number of new cases and the annual number of deaths from HIV and cervical cancer. And as you can see, HIV represents about 50,000 new cases each year compared to about 11,000 cases of cervical cancer. There are about 16,000 deaths attributable to HIV each year 4 times as many as the 4,000 deaths attributable to cervical cancer, yet no one really thinks twice about doing pap tests in order to screen for cervical cancer, but for some reason providers haven't thought that they needed to screen for HIV infection, even though there were more new cases and more deaths attributable to HIV. So the World Health Organization established criteria that justify routine screening for any condition. The first of those is that it has to be a serious health disorder that can be detected before symptoms develop that justifies screening. There has to be a reliable, inexpensive, and acceptable screening test in order to identify the condition. It has to be a condition for which treatment is more beneficial when it's begun when the disease is still asymptomatic, before any symptoms develop. The cost of screening needs to be reasonable in relation to the anticipated benefits for screening, and obviously treatment has to be available and accessible because the reason for conducting the screening is to put treatment into place when it can be of most benefit when people are still asymptomatic. And so the rationale for screening for HIV meets all of these criteria. This particular graph looks at the effectiveness of treatment. The curve in blue looks at the proportion of patients on highly active antiretroviral therapy, and the curve that's in pink is the death rate, the death per 100 person years. And what we can see is that as the proportion of patients increased, those two curves crossed just after 1996. 1996 was when highly active antiretroviral therapy and the class of drugs called protease inhibitors was introduced. They had a dramatic effect on survival, and subsequently the death rate from HIV has continued to decline as the proportion of patients on therapy has increased. There are several other effects from therapy, and one of them has been a dramatic reduction in hospitalizations. This looks at the incidence of hospitalizations among HIV-infected patients that were followed in CDC's long-standing HIV outpatient study. And that incidence rate of hospitalization per 100 person years diminished from about 25 hospitalizations in 1994 to less than half as many, about 12 hospitalizations in 2005. Another way to look at this is to compare the per-person gains in survival with various other interventions for diseases. This graph basically looks at the per-person survival gains in months as a result of chemotherapy for non-small cell lung cancer, for adjuvant chemotherapy for breast cancer with node involvement, for intensive post-MI care for people with coronary artery disease, and for bone marrow transplant with relapsed non-Hodgkin's lymphoma. And what we can see on the far right is antiretroviral therapy for AIDS results in a per-person survival gain of 160 months. That's nearly 13 years, exceeding any of the other interventions that we commonly employ for frequently encountered conditions. And these survival gains are really a significant reason for instituting therapy when we can maximize the benefit and improve the survival as much as possible. This next graph looks at survival among persons with HIV in the Athena National Cohort Study, which was conducted in the Netherlands. And what you can see in the solid line at the top is the median age reached by persons with HIV, not including persons diagnosed late, persons with AIDS. And the dotted line looks at survival in the general population depending on the age at diagnosis. And what you can see is that survival of persons with HIV in this era of therapy is essentially the same as people in the general population. People diagnosed with HIV early in the course of their infection and started on effective and appropriate therapy can basically expect a near normal life expectancy comparable to that seen in people in the general population without HIV infection. The next real issue is that screening works. This graph looks at the estimated number of acquired AIDS cases that were transmitted from mother to child between 1985 and 2005. And when AIDS was first identified in the mid-1980s, that rapidly increased from about 200 cases per year to a peak of nearly 1,000 cases per year in about 1993. It was then demonstrated that administering AZT or zidovudine could significantly influence transmission from mother to child. Shortly thereafter, in 1994, CDC issued recommendations for HIV screening of pregnant women. And subsequently, in the next 10 years, there's been a 95% reduction in the number of perinatally acquired AIDS cases to less than 50 per year by 2006. I think the next big reason to look at screening is that many HIV-infected people actually access health care, but they don't get tested for HIV. And this is an example from South Carolina. South Carolina has a system where they have a registry of healthcare visits, and the registry of healthcare visits looks at the number of visits and the diagnoses at different visits. And they compared their registry of all reported AIDS cases between 2001 and 2005 with this confidentially matched registry of healthcare visits during the time period 1997 to 2005. And this included visits to emergency departments, inpatient facilities at hospitals, ambulatory surgery facilities, and free medical clinics. And what they found is of the 4,315 reported HIV cases, over 3,000 patients, 73% of them, made more than 20,000 healthcare visits before they ever got tested for HIV infection. And when they looked at the diagnosis codes at these prior healthcare visits, more than 3/4 of the time, 77% of those prior visits were for a diagnosis that would not have prompted an HIV test. So it was not related to immune deficiency or to some symptom of HIV or even to an STD. They broke this down further and looked at people who were tested late, people who developed AIDS within 1 year of the HIV test, so they were certain to have been infected with HIV at the time of their prior visit, and found essentially the same statistics. Nearly 3/4 of patients made an average of 4 visits per patient, but they were never tested for HIV, despite accessing the healthcare system. Again, about 79% of these visits were made to emergency departments, and the diagnosis code in nearly 80% of these prior visits, even though these people had long-standing HIV disease, the diagnosis would not have prompted the need for an HIV test. The conclusion here is the only way to have identified these people earlier when they accessed the healthcare system was to institute screening for HIV infection. Another example comes from Kaiser Permanente, an HMO, and they looked at 440 patients who had new diagnoses of HIV. And again, they found that there was an average of nearly 9 healthcare contacts with each patient before they were ever tested for HIV. And their CD4 count at the time of diagnosis in 2/3 of cases was less than 350, the threshold at which therapy was indicated under prior recommendations. In 43% of cases, the CD4 count was less than 200. That's the threshold that defines immunologic AIDS. And in looking through these patients' chart, only 26% had risk factors that would have suggested the need for an HIV test. Well, the third rationale for HIV screening is because of its potential effect on the HIV epidemic. And here what we see basically is that when people undergo HIV testing and are identified as HIV positive, there are several things that happen. One is people can adopt safer behaviors in order to reduce the possibility of transmission. And the second that I'll describe in a little more detail is that when you treat people with antiretroviral therapy and they adhere to their therapy and maintain viral suppression, there is a decrease in HIV transmission. First, the behavioral effect. It has been demonstrated that after people become aware they're HIV positive, their prevalence of high-risk sexual behavior, that's unprotected anal or vaginal intercourse with HIV-negative partners, is 68% lower than people who are HIV infected but not aware of their infection. This is a meta-analysis that comes from about 22 different studies that looks at the effects of awareness on HIV transmission. And the important bottom line from this meta-analysis is that people who don't know that they're infected with HIV are 3.5 times more likely to transmit HIV infection than people with HIV who are aware of their infection. So simply on the basis of changes in behavior, The opportunity to reduce transmission is substantial, such that the 20% of people who don't know their HIV infection account for somewhere between half and 70% of all new HIV infections, whereas the transmission from 80% of people who know they're infected account for only approximately 1/3 of the 50,000 new sexually transmitted infections that occur each year in the United States. I think the second and most important information to have come to light recently, and this was just reported last month, is the results of the HIV Prevention Trials Network 052 study looking at antiretroviral therapy and transmission. In this study, they recruited HIV-infected patients who had CD4 counts between 350 and 550 cells per microliter, each of whom had an uninfected partner. This study was conducted across the world in Botswana, Brazil, India, Kenya, Malawi, South Africa, Thailand, as well as the United States. Patients who were HIV infected were randomized either to receive immediate antiretroviral therapy when their CD4 count was between 350 and 550, or deferred antiretroviral therapy when their CD4 count had fallen below 250 but was still above 200. And there were two endpoints in this study. One was primary transmission, to see how many infections were transmitted to these patients' uninfected sex partners. And there were a clinical endpoint, which looked at the development of WHO stage 4 disease, pulmonary tuberculosis, severe bacterial infections, or death. And what this study showed is out of the nearly 1,800 couples who were recruited, 97% of whom were heterosexual, there were 890 infected men, 873 women. There were a total of 39 transmissions during the follow-up period. They looked at the genetic makeup of the virus was transmitted to make sure that it was linked. In other words, that the virus that was acquired by the uninfected partner was the one that came from the infected partner. And what they found out of the 28 linked HIV transmissions in the group not receiving antiretroviral therapy, 27 transmissions occurred. In the group who started therapy early, only a single transmission occurred. And in fact, this transmission occurred right at the time the person was started on therapy, before they achieved viral suppression. And so this study demonstrated that putting people on antiretroviral therapy resulted in a 96% reduction in transmission of HIV infection. So in summary, the rationale for screening is that treatment is available, it improves survival, and it's definitely more effective when it's started early. As I've shown you, many HIV-infected people access health care, but they don't get tested for HIV until it's late, when they've already developed symptoms. HIV infection, being aware of HIV infection, leads to substantial reductions in high-risk sexual behavior and then reduces transmission. But in particular, earlier treatment with antiretroviral therapy and viral suppression substantially reduces HIV transmission by 96%. Now, the next consideration are testing approaches. Screening itself is performing an HIV test on all persons in a defined population. The approach of opt-out screening is performing an HIV test after notifying the patient that the test will be done, and consent is then inferred unless the patient declines. Opt-out testing is pretty much the way we do everything in medicine. When you recommend someone get a CBC or a cholesterol test, usually you just suggest it, and unless they say no or unless they refuse, but you just proceed. You don't go through a special, separate, or different procedure for obtaining consent. For a long period of time, the circumstance with HIV had been considerably different. There was a study that looked at prenatal HIV testing for pregnant women, where they obtained opt-in consent, where the women had to give separate consent for HIV testing. And in this study, they conducted a randomized controlled trial of 4 different counseling models, where testing was offered by the midwife, testing was offered by the obstetrician. It was done several different ways with short or long counseling. And in all 4 arms of the trial, only 35% of these pregnant women accepted HIV testing. And when they were interviewed, some of the women felt that accepting an HIV test gave some indication of promiscuity or high-risk sexual behavior. They didn't want to convey that message, and it was part of the reason that they declined an HIV test. In the same clinic, they basically switched to a method of opt-out testing, where testing was presented as a routine procedure that all women undertook. Women had the opportunity to decline testing, and testing increased in this group of women from 35% to 88%. And the women were interviewed, they indicated they were significantly less anxious about testing, that they felt that since it was routine, there was no reason particularly to turn it down. They didn't feel they had anything to worry about. And so this was the first of several demonstrations that showed the approach in testing, presenting it as a routine and not singling people out for an HIV test based on some kind of suspicion, dramatically increased the acceptance rate for HIV testing. So in 2006, CDC issued revised recommendations for HIV testing for adults, adolescents, and pregnant women in healthcare settings. And these recommendations called for providers to conduct routine voluntary HIV screening for all persons aged 13 to 64 in healthcare settings, not based on any kind of risk factor. These continued the previous recommendation that all patients with tuberculosis and all those seeking treatment for STDs should be screened for HIV. In addition, persons who were known to have risk factors, such as men who have sex with men or injection drug users, should be retested for HIV at least once a year. In addition, the recommendations called for using an RNA test in conjunction with an HIV antibody test when acute retroviral infection is a possibility. And I'll talk more in a few moments about acute retroviral infection. Now, recognizing that screening may not be justified in all settings, these screenings were based on the yield of screening, so that in settings where there was low, or as in most particular practices and hospital settings, people don't know what the prevalence of HIV is, the recommendations call for initiating screening, and if screening yielded less than one new infection per 1,000 persons screened, continued screening is not warranted. And so the issue here is that you don't screen without finding anybody, but what our experience has been in all places that have initiated screening, the yield has been greater than 1 per 1,000. And this threshold of 1 per 1,000 was made on the basis of cost-effectiveness studies showing that HIV screening was as cost-effective as other routinely involved interventions, such as, for example, mammography or pap smears, as long as the yield of new infections from screening was at least 1 in 1,000. The recommendations did call for opt-out HIV screening so that patients would have the opportunity to ask questions and the option to decline testing, but separate signed informed consent should not be required. At the time of these recommendations, many states still had either statutes or regulations that required separate signed informed consent. In the 5 years since the regulations, almost all states have revised those recommendations. I believe at the current time only Nebraska and Massachusetts require separate signed informed consent for HIV testing. In addition, these recommendations indicated that prevention counseling in conjunction with HIV screening should not be a requirement in healthcare settings. For a long time, counseling was always conducted with HIV testing. Certainly in the beginning, when a few people were familiar with HIV and were not familiar with the HIV test, counseling was necessary in order to raise people's awareness. However, studies with numerous providers indicated that a requirement for prevention counseling often discouraged providers from testing because of the time it took to conduct prevention counseling. In addition, surveys among patients looking at their AIDS knowledge and awareness indicated that there was much less need to educate people about HIV than there had been early in the epidemic. It's important to emphasize that screening is still voluntary. People do have the right to decline. Patients should be informed either orally or in writing with posters or brochures that HIV testing is planned and will be performed unless they decline. And obviously, it is essential to arrange for people who are HIV infected access to care, prevention, and support services. For pregnant women, the recommendations call for universal opt-out HIV screening during each pregnancy. It's recommended that HIV tests be included in the routine panel of prenatal screening tests, that consent for prenatal care include consent for HIV testing. Patients should be again notified and have the option to decline testing. In addition, a second test in the 3rd trimester is recommended for pregnant women who are known to be at high risk for HIV infection, in jurisdictions that have elevated HIV incidence, or in healthcare facilities with high HIV prevalence. As a result of the success of prenatal screening, it has been found that the majority of infants born to infected mothers who have not received therapy for their HIV infection during pregnancy occurred because the woman had tested negative early in pregnancy and then acquired HIV infection during her pregnancy before the infant was born. The recommendations call for opt-out rapid testing with the option to decline if a woman presents to labor and delivery with an undocumented HIV status, and if that rapid test is positive, antiretroviral prophylaxis should be initiated in the mother, because even if therapy is not instituted until the time of or immediately after birth, the likelihood of transmission can still be reduced by 50% by administering therapy. The recommendations also call, if the mother's status is unknown at the time of delivery, to conduct a rapid HIV test in the newborn and to initiate antiretroviral prophylaxis within 12 hours of birth on the basis of a positive rapid HIV test result. So I'd like to review, I guess, how we're doing since these recommendations were issued. I mentioned that the National Health Interview Survey had been asking people about whether they were tested for HIV ever and tested in the preceding 12 months, and these show the results basically between 1987 and 2006. The pink curve looks at the proportion of people who were ever tested, and the blue curve, the people who said they were tested in the preceding 12 months. And what you can see is the proportion of people who were tested for HIV, who said they'd ever been tested, had continued to increase between 1987 and early in 2001 and 2002. But starting at about the year 2003 through 2005, it stabilized such that the number of people tested remained at only about 40%. Now, the proportion of people who said they'd been tested within the last year remained relatively constant at 10%. So that if the same number of people say they were tested within the last year, but the total number of people who said they were ever tested doesn't increase, it pretty much means that we're probably retesting the same people as opposed to testing new individuals who might be at risk for HIV infection. So since the recommendations came out, the National Health Interview Survey has indicated progress. The proportion of people who reported they were ever tested increased from about 40% in 2006, when the recommendations were issued, to now just over 45% in 2009, not yet updated on this slide. This represents an increase of about 9 million people who say they've ever been tested, and an increase in the proportion of people who say they've been tested in the last 12 months of about 1.3 million persons per year. In addition, the number of diagnoses of HIV, the number of estimated cases of HIV and AIDS based on the 34 states that have confidential HIV reporting, has also increased between 2005 and 2007 by about 15%. So we're testing more people and we're identifying more HIV diagnoses. This graph looks at, I think, what we really had hoped for, which is that in the dark curve, you see the proportion of people who say they've ever been tested for HIV, which has now been increasing since 2006. And the dotted line looks at late HIV diagnoses, which has been going down. So that as we've been increasing testing, we have been identifying people earlier in the course of their disease, and fewer people are tested late in their disease, developing AIDS within a year of the time of their first positive HIV test. CDC initiated an expanded HIV testing initiative in October 2007, and these are the results through September of 2010. And what it looks at in the blue bars are the total number of HIV tests, and in the red bars, the HIV positive tests. And what you see is that in every setting where HIV screening was expanded, in emergency departments, STD clinics, correctional facilities, community health centers, wherever we tested people for HIV, we found a similar proportion of positive HIV tests. The one thing I think that's of some concern on this slide, second from the left, you see, is that testing among hospital inpatients, or at least expanded screening in inpatients, although patients were identified, the proportion who've been screened is very low. And I think that sets the next challenge for us, which is in addition to testing outpatients for HIV, we need to focus on testing people when they're admitted to the hospital. Last, I'm going to talk about HIV tests for just a moment. This looks at the course of HIV viremia and the antibody response. So that on this graph along the bottom line, 0.0 represents when a person becomes infected with HIV. The first marker to show up is HIV RNA, which can be measured in plasma. That's represented by the blue curve. Subsequent to that, a viral protein, HIV P24 antigen, develops at about 15 days after the time of infection, and subsequently HIV antibody develops. Most of our tests have been tests for HIV antibody, and the interval between the time of infection and the detection of antibody is the window period. And the important thing that I'd like to demonstrate is that not all HIV antibody tests are created equal. So that the earliest tests that were introduced, the first generation tests, detected only IgG antibodies for HIV. It picked up infection at approximately 2 months or 60 days after a person first became infected. Tests were improved in the second generation tests, which used synthetic peptides and recombinant proteins to detect antibody, reduced the window period to about 45 days. And then subsequently tests that were sensitive for both IgM and IgG antibodies were developed, which reduced this window period from infection to the first positive antibody test to a time period of about 25 days from the time of infection. The time period between the appearance of RNA and the appearance of antibody is defined, at least from a laboratory perspective, as an interval of acute HIV infection. And as you can see, since this is measured between RNA appearance and antibody appearance, that window period can be quite variable, so that while it's about 10 or 15 days with third generation antibody tests, it can be as long as 30 days for people who are tested with second generation tests that only detect IgG antibodies. And as I'll show you in a moment, most rapid HIV tests, in fact, use second generation principles. Another important consideration, first of all, is that if we are able to test for P24 antigen, and several tests have now been approved that test for both HIV antigen and antibody, we can reduce that period of acute infection to about 5 days. Importantly, each of these tests performs differently. This is a somewhat uninterpretable slide from CDC's laboratory, which looked at all the currently FDA-approved HIV tests against seroconverter panels. 183 specimens obtained from about 15 seroconverters who had been plasma donors and were bled at relatively frequent intervals, and we were able to look at these intervals to see how well the tests detected HIV and when the test detected HIV. And in order to make sense out of this, we drew a line across in order to see when the test detected 50% of all the people who were in the process of seroconverting. And this graph tries to put that in perspective with respect to the Western blot, which has long been used for the confirmatory tests. So that on this graph, the positive Western blot is at day 0, which is marked by the orange triangle. An indeterminate Western blot, when any bands show up on the Western blot, is marked by the yellow triangle. And what you can see is that the screening tests that had been in most commonplace use until 2007, the Diagnostic EIA antibody test, picked up infection about 2 days after the Western blot turned positive. At the next introduction here are with the lateral flow point-of-care rapid tests, the 4 of them, Clearview Complete, Clearview StatPack, or Quick and Unigold, all pick up infection between 2 days and 5 days between the time the Western blot turns positive. From the perspective of sending tests to the laboratory, rapid tests done in the laboratory called flow-through rapid tests, there are 2 of them, the Reveal and the MultiSpot, pick up infection about 10 days before the Western blot turns positive. And the laboratory tests that are used by commercial and public health laboratories are so-called third-generation tests, the one that detect IgM antibodies, pick up infection more than 2 weeks before the Western blot turns positive. And as you can see from this graph, these antibody tests will detect infection before the confirmatory test shows any evidence of infection, demonstrating there's a shortcoming to the confirmatory test. Finally, HIV RNA picks up infection about 25 days or about a month before the Western blot turns positive. Most recently, within the last 7 months, the FDA has approved 2 antigen-antibody combination tests. And as you see here, the antigen-antibody combination test, which is performed with the same ease as an EIA for antibody alone, picks up infection about 20 days before the Western blot turns positive, or only about 5 days after RNA first becomes detectable. So I want to talk for a moment about the clinical syndrome of acute HIV infection.
Dr. Branson,
Yes, ma'am.
we have a question, I'm sorry, before you go on. When you were speaking about the testing, can you say a little something about which tests are widely available for our clinical settings and approximately the cost to the patients that we are seeing in the underserved area?
The graph, as I go back here, is that almost all of these tests are available in the clinical setting. Certainly, if you send your test off to a referral laboratory like Quest or LabCorp, most of them will conduct the test indicated in blue here, the 3rd generation test, either the Bio-Rad or the Advia or the Vitros test. Most hospitals use platforms that, again, use the Advia or the Vitro, the 3rd generation tests. And those tests, of course, the difference between cost and price are 2 big things. In general, an antibody test like this will cost about $20, although the laboratory charge may be higher. On the right here are the rapid HIV tests. Rapid tests are widely available, and these are CLIA-waived rapid tests, which means that anyone who performs in-office testing can perform these lateral flow rapid tests because they're waived under CLIA. And these tests sell for between $8 and $12 per particular test. The antigen-antibody combination tests are just now becoming available, and we don't yet have pricing information for them. And the tests for RNA, some of the tests are viral load tests. Some of them are qualitative tests, which just detect the presence of RNA. These are available, again, from most laboratories, but they're considerably more expensive, ranging between $60 and $100 per HIV test. Sabrina, does that answer your question?
Yes, it does. Thank you.
Great, thank you. So in terms of acute infection, I want to mention this because between 40 and 90% of people, when they first become infected with HIV, will develop symptoms of acute HIV. And those symptoms are severe enough that in between half and up to 90% of the cases, people will seek medical care for their symptoms, but often they will go unrecognized. Of people diagnosed with acute HIV, half of patients are seen at least 3 times by their provider before the diagnosis is established. And the reason for that is that the symptoms are essentially symptoms of a viral illness. As you see here in a series of seroconverters, about 85% of people developed any symptom, but those symptoms were fatigue, fever, pharyngitis, lymphadenopathy, and rash, essentially the symptoms of infectious mononucleosis or any other kind of viral illness. The difficulty with acute infection is that it is highly infectious. This is a graph that looks at the rate of transmission by the different stage of infection. And in red, you see the first 3 months of HIV infection, where the transmission rate, 2.8, is about 30 times the transmission rate during long-standing asymptomatic infection, where the transmission rate is calculated at 0.1. And then because of the levels of virus in the system, the transmission rate again increases somewhat immediately before AIDS develops, late in the course of illness, to about 6 times that in the long-standing asymptomatic period. The key ingredient, though, is that this high infectiousness during the acute infection period really drives a lot of HIV transmission and the subsequent epidemic. So that in looking at HIV transmission by the different stage of infection, what you see here in red is the acute infection stage, which lasts only for between 4 weeks and 12 weeks. It's responsible for nearly 31% of all new HIV transmissions, so that nearly a third of all new cases of HIV in patients who have multiple partners are attributable to this period of acute infection, which is very brief at the very early stage of HIV. So that recognized acute infection and helping to intervene so that people don't transmit with acute HIV infection is important. And that's the reason why first it was recommended to use an RNA test in conjunction with an antibody test when a person has risk factors for HIV and symptoms of a viral illness. Now I think it will be easier to screen as the antigen-antibody combination tests become widely available because they will also detect acute infection. Of particular importance is acute infections among men who have sex with men. There have been several studies conducted using RNA screening on specimens from people who tested negative for antibody when they went in to seek HIV testing. And as you see here, among frequently tested men who have sex with men in an STD clinic in Seattle, acute infection represented 20% of all the people with HIV infection, meaning that when people were seeking an HIV test, 20% of them were infected but were negative on antibody tests. It's similarly in a clinic for men who have sex with men in Los Angeles. Of 35 acute HIV infection cases in Los Angeles, 3/4 of them were among men who have sex with men, where they represented 25% of all HIV infections detected. And even in STD clinics with high-risk heterosexual and men who have sex with men, acute infections represented 9% of all infections detected. In other words, nearly 10% of HIV-infected people would have tested negative on an antibody test. And again, the vast majority of these were men who have sex with men. So the need to look for acute infections is particularly important among this population. Excuse me. The fourth generation tests, as I mentioned, compared to RNA, are actually very sensitive for acute infection. So that in several different studies, it showed that these new fourth generation tests will detect about 80 to 85% of infections that were otherwise detectable only with RNA. And looking at seroconversion panels, the fourth generation antigen antibody test will detect infection only about 4 or 5 days after RNA becomes positive. So one thing that this is important with respect to the practicing physician is our current process of so-called confirmatory testing has a number of limitations. As I showed you on that graph, the Western blot is less sensitive during early infection than most screening tests that we currently use. The antigen-antibody combination tests will detect specimens in people who are completely negative for antibody during the highly infectious acute stage. And something that I haven't shown you, but has become increasingly evident, is that there is cross-reaction between HIV-1 and HIV-2, and so that people with HIV-2 infection will receive a positive result on an HIV-1 Western blot and be misdiagnosed with HIV-1. This is important because a large number of the medications effective against HIV-1 don't work with HIV-2 infection. So currently, the CDC is proposing a new diagnostic algorithm for screening that does not include Western blot testing that people need to become familiar with. This will start with a very sensitive third or fourth generation immunoassay. If that's negative, the person is considered negative for HIV infection. If that's positive, then it will be subjected to an antibody test that differentiates HIV-1 from HIV-2. If that's positive for HIV-1 antibodies or HIV-2 antibodies, that person should be recommended for medical care. If this antibody test is negative, the specimen would go on to get an RNA test, such that people who are detected by the sensitive initial test and have acute infection would be identified even if they're negative for antibodies by the antibody differentiation test. And currently, the antibody differentiation test is the MultiSpot rapid test, which can be performed in 15 minutes. It's available in most hospital and in all clinical laboratories. And so the vast majority of people who have a positive antibody screening test can receive a confirmed diagnosis based on this FDA-approved discriminatory test, and potentially testing the entire sequence can take less than an hour. So the implications here is that we will have the ability to detect acute HIV infection, which will help us to focus our partner services and intervention efforts to reduce transmission, and we'll also have the ability to detect HIV-2 infection, which gives false negative results with many viral load tests, and which does not respond to many of the antiretroviral drugs, including the non-nucleoside reverse transcriptase inhibitors and several protease inhibitors, both of which are part of currently recommended first-line therapy. So, in conclusion, I would like to mention that another part of these revised recommendations is that healthcare providers should encourage their patients and their prospective sex partners to be tested for HIV and to know their HIV status before they initiate a new sexual relationship, in order to take steps, if necessary, to prevent the possible transmission of HIV infection Which brings us to sort of the end of my presentation and to sort of a new era. Back in the 1950s, it was perhaps routine for people to get married before they took the big step. In the 1970s, as you can see in this cartoon, perhaps they would use drugs, and in the 1990s through the 2000s, we're encouraging people to get tested first. So that ends my presentation, and I would be happy to respond to any questions that people might have.
I do see someone's hand raised. So Danielle, we need you to type your question into the box and click submit. So nothing's up yet. I would like to say thank you, Dr. Branson, while we're waiting for that question to come in, for an insightful and engaging presentation tonight. Very detailed and very good information for us primary care clinicians. I was wondering, do you have any suggestions on just an easy way to bring up that conversation with our clients? You know, sometimes when they're coming in for STD things, then you bring up the HIV talk. But just a sample conversation of, you know, hey, since we're doing your physical today, we're offering an HIV test. Is that how you would recommend us to phrase it, or do you have any suggestions there?
I think that the thing we found is most effective is for people to say that I recommend all my patients get tested for HIV because there's a lot of treatment that is available should you have HIV infection. Although it's relatively uncommon, it's important to find it. So as opposed to offering and saying, would you like an HIV test, patients say that they prefer when their physicians recommend the test, when they indicate that it's something they offer to everyone when they come in for physical examination, and certainly when they come in for an STD. And that patients, in fact, increasingly aware of these recommendations, are surprised when their physicians don't offer the test.
Right. Well, we do have a question now. This person says, sorry, I missed part of the presentation. Do you recommend routine HIV screening even in the 13 to 17-year-olds who deny sexual activities in the community health center settings?
You know, I think that is a question that has provoked a tremendous amount of discussion. You know, there's several ways to answer it. One of them, of course, is it depends on whether their parents are there with them or not. Because very often people, youngsters, adolescents will not acknowledge sexual activity when they're in that environment. They may be embarrassed with the provider. They may be embarrassed when their parents are there to acknowledge sexual activity. And so in general, what we recommend is that screening be offered and the patient have the opportunity to decline screening, as opposed to having to acknowledge sexual activity first and then be so-called eligible for an HIV test. So we would recommend that screening be presented to adolescents as a recommendation. One of the problems with the most recent incidence data is that the biggest increases in new infections are in fact happening in the age group between 15 and 55. And so, although certainly people who haven't been sexually active don't need to test, it's not always easy to ascertain with certainty whether or not an adolescent has in fact been sexually active.
Right. All right, we have another question. I work in a mobile homeless program in New York City, and we have actually adopted routine testing of everyone 18 and over. We usually don't test younger than that unless they admit to high-risk activity.
I think that we certainly encourage people to do screening, whatever seems to make sense in their environment. In a homeless shelter, I would be a little concerned about not testing young people, since many young people, in fact, resort to prostitution or exchange sex for money or drugs just on a survival basis. And so I think that I would have some concern about not offering HIV testing to persons who are younger than 18. Again, expecting people to so-called admit to high-risk activity places the onus on them to so-called confess something they might rather not reveal, and so it's an awkward situation.
Okay. Well, I don't see any more questions, but if they do, we'll get to them. I would like to make a few announcements. I want to invite our audience to stick with us as this presentation ends. There'll be an evaluation that'll be tied to your CME. So please hang on to the very, very end so that you're able to fill that out for your CE credit. Please note that on our website in the resource area under clinical excellence, there are links to some organizations to give you more info on HIV treatment, the newly updated recommendations, resources, and testing. Those websites include the CDC HIV resource page, as well as the National Center for HIV/AIDS, viral hepatitis, STD, and TB prevention at the CDC page. I would like to also invite you to join us tomorrow night on Thursday for a very special Meet the Speaker with Dr. Ellen Beck from UC San Diego, and she'll be entertaining the topic of work-life balance. It'll be a very interactive session where you'll be able to initiate your microphones and join in the conversation. So please come out tomorrow night from 8 to 9 p.m. Eastern Time. And then next week, Thursday, and Friday, we'll be streaming live from our annual Primary Care and Prevention Conference. It'll start at 9:30 in the morning Eastern Time and stream all day. Also, we will not have a Wednesday night webinar next week, but we will stream live Thursday and Friday. Again, this series has been made possible through a partnership between the National Center for Primary Care, the Migrant Clinicians Network, ACU, Clinical Directors Network, and the National Healthcare for the Homeless Council. We do have one more question, and it's from Consuela, who says, can you offer advice on convincing medical leadership to change to the opt-out screening? I work in the FQHC in Indianapolis, and we are still asking patients to sign written consents for HIV testing.
I wish I had an easy solution for you and how to handle that circumstance. Very often people have a habit that's ingrained for a long period of time, and it's hard to get them to change. In general, what we attempt to do is to cite the increasing number of studies, the evidence that shows a large difference in acceptance rates when you do the opt-out model versus requiring people to sign informed consent, as well as now there's an annual Kaiser Family Foundation survey, and if you go to kff.org, there was also that survey where it indicates that nearly 3/4 of people say they prefer that HIV be treated just like any other condition and not be singled out in order to do something separate. Communicating that to leadership is, I think, sometimes difficult, and the only thing I can recommend in that circumstance is persistence.
Well, that'll be the last question we take tonight. Thank you again, Dr. Branson, for this presentation tonight. I will also remind our audience that this webinar tonight has been recorded, and it will be stored in our on-demand section of our website, so it'll be available for review. Thank you again. Please remember to complete your CE evaluations and have a great evening.
Great. Thank you.